siapa? Nazril.
Nazril.
Design apa?
Peripheral IV cannulation dengan venipuncture.
Okay.
Okay. Okay. Okay, by definition, as you can see from the picture, it is a cannula or catheter inserted into small peripheral for therapeutic purpose, such, for example, administration of medication, fluids, or blood products. Okay. For indication, for peripheral, usually it is for short-term indication, which we delivery of intravenous fluids to replace and maintain fluid. Example, when the patient is having diarrhea, that may lead to fluid loss. And then next is to administer blood product, especially in surgery, where patient need extra blood along the surgery. And the next is to administer medication such as chemotherapy or analgesics. And last one is to deliver nutrition, especially in malnourished infants. However, take note that in pediatrics, most of the children do not need vascular access for medication because it can be accessed by other non-invasive route, for example, oral, transmucosal, or inhalation. And also finding veins in infants is quite challenging due to the small size of the vein. Okay, next, for catheter selection, for newborn and infants, we use 22 to 24 gauge, and for older children, we use 18 to 20 gauge. Okay, for sites, most common sites for pediatrics is the dorsal of the hand and also feet. And then the next sites that's available is at the antecubital fossa, at the forearm, which locate the cephalic vein, basilic vein, and also median cubital vein.
Jarang lah pakai forearm. Jadi biasanya pakai dorsal vein ya.
And the last one is at the scalp, which used in infants below 1 years old. However, it is less desirable due to the scalp maybe have to be shaved before the injection to expose the vein and also the parents' consent.
The main problem is that the scalp also got artery. Sometimes difficult to differentiate between artery and vein.
And then for equipment, the equipment that we need is glove, alcohol swab to prevent contamination, tronic, ethyl chloride spray that used to prevent pain caused by the injection, catheter, transparent dressing, heparin saline. Heparin saline is used in the first step, which we flush into the catheter to prevent blood from clotting and prevent complication. And then gauze
Chloride spray itu pakai untuk apa? Ethyl chloride spray tu pakai untuk apa?
Saya baca dia spray dekat injection.
Dia tak pakai spray lah, oi. Swab dia terus.
And then protective covering IV such as plastic cup and also tape. Okay. I have the video of the presentation.
Biasa kita pakai dekat dorsal.
So this is the detailed procedure that you can read. Next, later, the step by step of the procedure. Start from step 1, which is we apply the tonic to visible the vein, and then before the injection, and then the first flashback, and then the second flashback, And the last one is push of the plate of the heater hub. Okay, for contraindication, firstly, for contraindication is that we must not use IV cannulation if other other non-investigation prevent from injection this with trauma and also or and last to a patient with bleeding diastasis, because patient with bleeding diastasis will bleed easily and blood will not clot properly. And then for complication there are two, which is the first one is local and also systemic. For most common complication is hematoma, and then phlebitis, infection, infiltration, and also extravasation. Uh, Take note that phlebitis, infiltration, the difference between phlebitis, infiltration, and also extravasation. Phlebitis is inflammation of the vein, and the patient might feel pain and redness, and also increased skin temperature at the site of injection. However, for infiltration, it is a leakage of intravenous solution into the extravascular tissue, and the patient might have edema, pallor, and also lower skin temperature around the site of injection. For extravasation, it is quite similar to infiltration, which is a leakage of the solution into the surrounding tissue. However, the extravasation solution is a type of solution that can cause irritation and also damage to the tissue. So the patient might feel pain, stinging, burning, and swelling, and also redness at the site of the injection. And then we have a systemic complication, which is air embolism and also catheter-related infection. So catheter-related infection is when the contamination happen and microorganism able to enter the puncture site, may lead to sepsis or bacteremia. Okay, the first picture is picture of phlebitis. You can see the redness streak at the vein, along the vein, and the next picture at the center is extravasation. So you can see the destruction of the tissue at the site of injection. And the last picture is infiltration. There are no destruction of tissue. However, there are edema and also pallor. Okay. Next is venipuncture. So venipuncture is a surgical puncture of a vein, especially for the withdrawal of blood. So basically, we want to collect the blood sample for the patient. And for the sites, for children that is more than 2 years old, we usually use at the antecubital fossa. And for children which is less than 2 years old, we use at the hand, dorsal of the hand. And for equipment, the equipment is quite similar to peripheral IV cannulation. Just add evacuated tube for us to collect the blood, and also butterfly, which is an extension tube. Other equipment is basically same. Okay. This is a short video of
Besar jarum dia pakai. Banyak darah dia ambil. Kira kan baby apa tu? Besar tu punya apa? Dia punya ni.
Okay. So this is the procedure that I've cut from the video, step by step. Start with disinfect the hand, and then how to hold this the catheter, and then until on the flashback of the blood. Okay.
Darah dia ambil banyak sangat tu, Nazri.
Oh, banyak sangat.
Dia tu besar sangat dia tu. Furthermore, jarum kita pakai kena kecil je. Cucuk pun dalam tu sampai sepanjang tu I think we are more careful than this fella yang buat gambar ni. Cucuk sikit je.
Jarum 21 ni.
Kita pakai small je. Kita punya ni nak ambil darah tu, kita punya tu small je. Ni tabur uji dia kartu blood collection tu banyak tu. Dia pakai besar punya apa tu? Sling tu. Pediatrik tu orang klinik pediatrik semua kecil je ketuk pin. Ini kalau ambil darah macam ni 5 kali ambil darah, budak tu anemia lah. Continue lah.
Is contraindication. Okay. For contraindication, okay, we must same like peripheral IV. We must prevent to do this procedure to a bleeding disease patient. And then for complication, prolonged bleeding if the patient have bleeding
disease is not contraindication. Kalau kita perlu ambil, kita kena perlu ambil lah. Cuma kita tekan lama. Ini biasanya hematoma ni because you tak tekan lama. Kalau budak orang tu ada bleeding disease, biasanya tekan lama. Bila tekan lama tu prevent the blood clot, hematoma.
Okay, okay, that's all.
Okay, next. Siapa pula?
Me, doktor.
Siapa nama ni?
Fatin Atira.
Panca.
Nama Panca.
Nur Fatin berapa orang nama?
Nur Fatin.
Nur Fatin berapa orang nama?
Berapa orang nama? Satu orang je.
Ya, Nur Fatin berapa orang satu grup.
Okay. Okay, so Assalamualaikum warahmatullahi wabarakatuh. I'm Nur Fatin Atira and I will present about lumbar puncture in pediatric. So this is my outline, so my contents. So I'm going to start with basic concept from anatomy until the complication of the lumbar puncture. So introduction. Okay, so lumbar puncture refers to the insertion of a specialized needle into the lumbar subaronoid space to gain access to cerebrospinal fluid. So in order for us to obtain the CSF, we need to know for the anatomy. So anatomy, we have to go through layer by layer from the superficial part, which is the skin, subcutaneous fat, and until we reach the subaronoid space. So for the surrounding space is where the CSF contain. And then for the puncture site, so as we look at this picture at the right side, so during birth, at birth, the inferior tip of the spinal cord will end at the L3. So as vertebral column grows during adulthood and older children, the inferior tip will end at L1. And then, so where to do the lumbar puncture? We do it at the below the termination of spinal cord. So in pediatric protocols, we do at L3 to L4 interspace. So how to know this L3 and L4? So the landmark is first we have to know. So in this picture at the right, at the left side, so we have to know the surface anatomy first and palpate, locate the highest point of both iliac crest, which is the posterior superior iliac crest. Okay, so and then if we have located it and draw imaginary line that connects these two highest point, which is the red line here. So the intersection between red line, this line, and the midline of the spine is approximately at the level between vertebrae L3 to L4. So this is the L3 to L4 interspace. Okay, so lumbar puncture, the indication is we do when we suspect any central nervous system infection, for example, like meningitis, encephalitis, or suspect any subarachnoid hemorrhage. So we can assess for opening pressure or any red blood cell in the CSF, and also to diagnose and treatment of intracranial hypertension or neurologic condition, for example, like Guillain-Barré syndrome. And we do also do a spinal anesthesia and prevention of CNS malignancy. Okay. However, not all children are approved to do lumbar puncture. So there are several contraindications. Okay, so the first one is increase in intracranial pressure. So if the children has increase in ICP, it can risk to brain herniation. So before the procedure, we need to check the sign and symptom of the increase in ICP, and also we do the CT scan or MRI of the brain before lumbar puncture, as well as children who has bleeding tendency, for example, like severe thrombocytopenia or prolonged PT or APTT, that can get risk to spinal hematoma. And also children who has respiratory distress. Sorry for the two. Okay, so the children can get risk of hypoxemia or apnea during procedure, as well as hemodynamic instability. So children with shock should undergo appropriate resuscitation first before doing the lumbar puncture. And the last one is skin infection, for example, like cellulitis during at the puncture site. So it can get risk, increase the risk of carrying the infection into the CSF with lumbar puncture needle that can lead to sepsis. Okay, so for the preparation, okay, so first we have to evaluate whether this patient is fit enough for the procedure. So we need to rule out if there is any contraindication, like I mentioned before, and also monitor of oxygen saturation, the respiration, the heart rate, and if these children needs to do neuroimaging first before lumbar puncture. And the second one is counseling, is very important. So even though lumbar puncture is like a simple and safe procedure, but not all children and families and their families allowed to do it. So we need to give a clear explanation of urgent indication and also details of the procedure. So and we also need to tell some complication of lumbar puncture, and we are advised to get a written informed consent to prevent any problems in the future. And for the third one is the equipment. So like I've listed here the equipment. So the important one is the needle itself. We use the spinal needle. So the spinal needle is 20 to 22 gauge, and the length is about 1.5 inch with stylet. But for children with over 12 years old, we use longer needle, which is 3.5 inch. Okay, so for the procedure, first, we have to give sedation, apply local anesthetic to 30 to 45 minutes prior to procedure to minimize the pain, and also we position. So we can either do in lateral recumbent. Next slide, I will show the picture. Okay, so we can do in either lateral recumbent or in sitting position. For the sitting position, it may prefer in children who have potential to develop respiratory compromise because of hyperflexion of the neck in lateral recumbent position. And the third one is we identify the puncture site, which is at the L3 to L4 interspace, like I mentioned before. And then using the sterile technique, we clean the puncture site with povidone iodine and 70% of alcohol. And we drape the puncture site area. So once the patient is properly positioned and the area is sterilized, we gently insert the spinal needle to the puncture site and points toward the umbilicus. And during the penetration, we may feel some resistance due to the tip of the needle passes through the interspinous ligament. And once we gently advance a few millimeters at a time, there is and until we feel some characteristic like a pop. So this pop indicates like the needle has penetrated the dura mater and entered the subaerial space. And then we withdraw the needle, the stylet, and then check for the backflow of the CSF. So when the CSF returns occur, we can measure the opening pressure by attach the needle to a manometer. And then we collect CSF in the designated bottle. So this designated bottle, usually we use four tubes. And then we gently withdraw the needle and spray with outside the dressing, cover with gauze and bandage. And we ensure the children will lie supine for the next 4 to 6 hours. Okay, so this is the picture that I've mentioned. So we can either do in sitting or lateral recumbent position. So for further understanding, let's watch a video.
Positioning of the infant is critical for a successful lumbar puncture. You need a good helper to position and hold the infant. Your assistant should be experienced and should respond to your feedback about positioning. The helper will hold the hips and shoulders, curling the child in a position to open up the interspinous processes. Infant lumbar punctures are typically not sedated, so the infant must be firmly held. Many helpers tend to curl the baby away from you, rolling their spine upwards. However, it is essential that the length of the baby's spinal cord is parallel to the table. Remember, the right alignment is critical. Also note, lumbar puncture can be done with the patient sitting up and curled forward. This is more commonly done in older adolescent patients. This is not shown in the video. Cleaning of the site should be performed in a circular motion, working from the inside out. Clean well beyond the area you will drape with chlorhexidine and betadine. Do this 3 times. The baby's diaper should be off by this point. Place your drape so as to create an opening through which everything is sterile. There are a number of different ways to drape the child. One is shown here. It is now time to perform the procedure and obtain the cerebrospinal fluid. Remember that your needle must have a stylet in it. The stylet needs to be in, or else tissue can be pushed into the spinal canal. This can cause a devastating local reaction. Make sure that you are comfortable. Many people prefer to be sitting during the procedure, in which case it is important to make sure the surface that the infant is on is at an appropriate height. Stabilize your dominant hand on the baby's sacrum and aim towards the umbilicus. You should aim towards the umbilicus so that you can pass between the spinous processes. If you go in perpendicular to the skin, you are much more likely to hit bone, as you can see in this model. As you move the needle in, you may or may not feel a change in resistance, often called a pop. If you're not sure if there has been a change in resistance, periodically take the stylet out and see if there is CSF flow. If you cannot get flow, put the stylet back in and go a bit further. Recheck periodically. Once you have flow, collect the fluid in 3 to 4 tubes. If you can, get about 1 centimeter in each tube. Reinsert the stylet, take the needle out, and put pressure on the site with gauze. You can then dispose of sharps. Put a band-aid on and tell the patient and their family that the child should remain supine for at least 30 minutes to minimize the potential post-tap headache.
Okay, so that's all for the procedure. Okay, so the last one is complication. So the most common complication of the lumbar puncture is the post-spinal headache. So post-spinal headache is because of the leakage of the spinal fluid through a puncture hole in the dura mater. So some say that to prevent this, we use smallest possible needle. And then second one is back pain. So back pain usually resolve within few days. And the third one is infection. This can prevent by using proper sterile technique. And the last one is cerebral herniation. This is rare, but the most serious complication of lumbar puncture. This occur because we do lumbar puncture in children with increased intracranial pressure. So I think that's all from me. Thank you.
Okay, next. Siapa?
Ni Doktor, Muhammad Hafiz.
Muhammad. Tak nampak? Nama siapa? Hafiz.
Syafi'i.
Tak nampak muka you mana?
Sini.
Tracheal intubation. Okay.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So I'll be presenting about endotracheal intubation. So endotracheal intubation basically is a placement of a flexible tube into the trachea through the oral cavity for airway management. For example, we want the patient to get enough oxygen. And then indication for the endotracheal intubation is when back and mask ventilation, or also known as the continuous non-invasive positive airway pressure, is insufficient. For example, in the case of severe COPD. So other indication is prolonged positive pressure ventilator, direct suction of the trachea when coughing is not enough to eliminate the fluid inside the respiratory tract and to maintain and protect the airway. For example, when someone undergoes surgery and under general anesthesia. And it also indicated for the diaphragmatic hernia. For diaphragmatic hernia, we cannot use the back and mask ventilator because back and mask ventilator, it will cause the distension of the stomach and the intestine and cause respiratory, it will affect the respiratory. And then for the contraindication, this method is used in the condition that is acute, so an emergency condition. So there is no absolute contraindication, especially when it is done by a practice person. However, in an experienced person, they can do the back and mask ventilation first until the help arrives before they can do the intubation. But of course, it is contraindicated in diaphragmatic hernia. And then for the equipment, the first equipment we can use, there are back and mask with high flow oxygen, and then laryngoscope. So laryngoscope is the device that we use to get a better view of the larynx. And then blade, we have two blades, Miller blade and Macintosh blade. For the Miller blade, we use in the infant and Macintosh in the older children. And endotracheal tube is a flexible tube that will be inserted into the trachea. And stylet. So stylet will be used with endotracheal tube just to guide the endotracheal before so that it will be easily inserted into the trachea. However, it is optional. And then suction catheter and device, adhesive tape for secure the endotracheal tube, pulse oximeter to check its oxygen, and sedation and muscle relaxant. For sedation, we can use midazolam and morphine, and muscle relaxant, it can be used to ease the insertion of the endotracheal tube. They are the rocuronium and succinylcholine. Next, we move on to the pre-procedure. So before we start, we need to position the infant in a sniffing position. So to make it easy, sniffing position is when the oral axis pharynx exists and the trachea exists is aligned to each other. And we give pre-oxygenation using back and mask ventilation and give medication, sedation and muscle relaxant. And along the procedure, we need to measure the vital sign, And then we start the procedure. First, we need to open the patient mouth, introduce the blade and push the tongue away and advance to the back of the tongue so that we can get
Apa khabar?
so we get a better view of the
Okay.
pharynx. So here a little bit of the anatomy. A, we have the glottis, B is the vocal cord, and C the epiglottis. So when the epiglottis is seen, we will lift the blade upward and outward, just like in the picture, to visualize the vocal cord.
Finance.
And then after we have visualized the vocal cord, we might use suction to suck the secretion if necessary. And by using the right hand, we will insert the endotracheal tube into the infant mouth, and pilot may be required. And then we will insert the endotracheal tube when the vocal cord are open and into the desired line. So it depends on the age of the infant or the children. And if the intubation is not done within 20 seconds, the attempt should be aborted and reventilation with bag and mask. For the pre-oxygenation, it can be skipped if it's an emergency condition. So we just continue with the procedure. So once intubated is done, so we will remove the laryngoscope and hold the endotracheal tube firmly with the left hand and connect the self-inflating bag and positive pressure ventilation to confirm the position of the endotracheal tube by looking of the chest expansion and listen to the lung entry to the lung and to the stomach. And then once we have confirmed the position, we can secure the endotracheal tube with adhesive tape and connect the endotracheal tube to the ventilator or resuscitation bag. And we may want to check for chest radiography to further confirm the position of the endotracheal tube. Then for the complication, several complications. First, esophageal intubation. So for the esophageal intubation, initially the endotracheal tube may be in the trachea. However, it might be dislodged and enter into the esophagus. And then right lung intubation, when the endotracheal tube is inserted too far that it inserted into the right lung. Then trauma to the upper airway, because this procedure is an invasive anyway. And then a pneumothorax due to the high pressure of the air that is entered into the lung. And then subglottic stenosis. So subglottis is a structure under the vocal cord and above the trachea. However, the subglottic stenosis is a late presentation of the complication. Yeah, that's all for me.
Okay, balik semula. Lagi. Okay. Okay, pergi forward. Okay, forward. Okay, forward. Video mana?
Video tak ada sebab dia macam terlalu
Oh, cari video nanti.
Okay.
You kena apa tu? That is one thing, tapi cari satu banyak video dalam YouTube, cari je. How to intubate children. Ni video panjang sangat. As you all know macam mana been done. So you hutang satu video.
Okay.
Video compulsory. Next. Kan, tak? You all macam mana? Should ada video ke tak ada video? Apa pendapat you all?
Video.
Video sure kan. So video ni dia kata orang tu it can give dia boleh 1000 words kan. Kalau video is better tu ni. Dan you boleh ingat video ni. And so make use of the learning process yang the video ni. Rugi ke tak guna? Next. Siapa presenter ni? Habis dah?
Can you guys see my slide?
No apa? No Hafira.
Yes, Hafira.
Okay, ha. Okay.
I'm Hafira binti Muhammad. We'll be talking about the nebulizers, those are also called as MDI. So this is my outline for today. So a brief introduction for these two devices. For nebulizers, it is defined as the devices that transform solutions or suspensions of medications into aerosols that are optimal in the lower airways, which is the lungs. For MDI, it is defined as a handheld aerosol device that uses a propellant to deliver the therapeutic agent, and it is recommended to be used together with spacer. Spacer is an external device that has mouthpiece or face mask that will attach to the MDI. And these two devices are the most...
No Hafira.
Yes, Doctor.
Dia rumah dia kat mana?
Johor Bahru.
Oh. Jauh. Okay, ha. Continue.
And these two devices are among the popular mode of aerosol delivery, and it is designed specifically to generate relatively small particles that can bypass the filtering action of upper airways and deposits in lower airways. So mainly for these two devices, it is indicated to treat respiratory disorders. For example, bronchospasm, which is commonly caused by asthma, and obstructive lung disorders, for example, COPD, cystic fibrosis, pulmonary arterial hypertension, and also infectious pulmonary disease. For nebulizers, it is most beneficial when, for nebulizers, it can be used for any age, but it is most beneficial when we need to administer large inhaled drug doses. Other than that, when patients are too unwell and unable to coordinate drug delivery, for example, the patient unable to take a deep breath. And next, nebulizer is used when drugs are unavailable in handheld inhalers, for example, antibiotics administration. And also, it is most beneficial when it is used to direct pulmonary therapy when direct pulmonary therapy is required. And for MDI, these are some of the advantages, which is it is more portable and more convenient. It's easy and rapid administrations, more efficient, and has less side effects. As I mentioned just now, MDI is usually we use together with spacer. It is because this device, it is more make the it is easier to coordinate, which is great for younger children and elderly. And other than that, this spacer will hold the medication from the MDI to waste less, meaning that there will prevent the medicine to escape into the air. And it also extends amount of time for reaching the lungs. As compared as when you use MDI alone, there is high chance of the medication to leave at the back of the throat. And when this happens, the medication will be swallowed and cause side effects. Next. According to the Malaysian guidelines, home nebulizer therapy is no longer discouraged as it is highly inefficient because much of the prescribed dose is caught in internal apparatus and wasted during exhalation. And apart from this, evidence has suggested that metered dose inhalers (MDI) are as effective as nebulizers. So there's no use of using home nebulizer therapy anymore. Next, these are some of the contraindications. The first one is patient with unstable and increased blood pressure, individuals with cardiac irritability, which may result to dysrhythmias, and persons with increased pulses, and also in unconscious patient because the therapeutic effect may be low. Next, we're moving on to the procedure or the technique. First, we start with the nebulizer first. As you guys can see on the top right picture above is the set of nebulizer apparatus, which mainly consists of air compressor, mouthpiece or face mask, nebulizer cup, air filter, and tubing. So first of all, we need to assemble the nebulizer apparatus and plug in the power source and place on a steady surface. And then we place the medication in the nebulizer cup and close it. There are several types of medication and solution and can be delivered through this nebulizer. For example, saline water, bronchodilator, steroids, and also antibiotics. Next, we attach the top portion of the nebulizer cup to the mouthpiece or face mask, and then connect the bottom nebulizer cup with tubing to the air compressor. Then we ask the patient to sit up comfortably straight, and then ask the patient to use the nebulizer, and we turn on the oxygen or air compressor. Sometimes oxygen also can be used to drive the nebulizer if the oxygen level in patient is low. And then ask the patient to breathe through the mouth with slow inspiratory flow and occasional deep breaths. And this process, this nebulization therapy usually takes around 5 to 10 minutes to nebulize and deliver the medication. Lastly, turn off the nebulizer and clean up. Next is the procedure or techniques for MDIs. So this in the right picture is the MDI. Basically, mainly consists of canister. This canister usually contains the pharmacology agent such as bronchodilator or steroids, and also plastic holder that house the canister, and also the cap to close the MDI. On the right picture is the spacer. So the technique to use this MDIs is very simple. We advise the patient to sitting up comfortably straight, and then ask the patient to remove the cap, shake the inhaler, and if you use spacer, insert spacer into the inhaler, and then ask the patient to slowly breathe out completely for 3 to 5 seconds, and then use the device in one of these 3 positions. So these 3 positions, this is consists of A, B, and C. These positions of A and B are the best, but if the patient unable to do so in A and B, position C can be used. Next, we ask the patient, after use this inhaler, we ask the patient to simultaneously breathe in slowly through the mouth and press down on the inhaler 1 time, and then ask the patient to hold breath for a count of 10. And after a count of 10, slowly breathe out, and
Salah
and
cara
then
ni.
repeat the process if
Ni salah.
sorry, which one is salah?
Mana-mana dikutip ni. Salah. Tak payah hold the breath. Goncang, tekan. After that you tarik nafas 5 kali, habis. Tak payah hold the breath semua tu.
Okay.
You kalau ada apa tu
But,
dalam exam tu apa tu kosong markah nanti.
Okay, doctor. So no need
Ini
to
kalau
breath,
tak payah
just,
pakai MDI. Kalau ini tekan tak pakai spacer. Tarik nafas. Nafas ya.
okay, so
Tahu
no need to.
Tak payah.
Okay. So just ignore the whole breath tu. and then slowly
You
breathe out
tengok
and
kita punya protokol macam mana?
and then repeat the process if more than one puff is prescribed. And within that puff, between wait for 1 minute.
Tak payah tunggu 1 minit.
Okay,
Hmm.
no need to wait. Okay, next, this is
Tak payah.
some of the side effects and complications for nebulizer. There is mild side effects, which is rapid heartbeat, mild tremor, dizziness, and dryness of the mouth. For MDI, specifically particularly for steroid inhaler, some patients may experience sore mouth or throat, hoarse or croaky voice, cough, oral thrush, and also nosebleeds. The complications usually due to the bacterial contamination of the special device or the nebulizer tubing and hand unit. So we need to clean up after use. I think this is all for my presentation.
Video?
Sorry, Doctor.
Video?
Oh, I couldn't include the video because there is problem when I try to insert the video. Yes. Tak tahu dia ada masalah, betul dia macam tak boleh nak load video dia.
Yeah, tapi next time try again.
I will. Okay. I will send the video link through the WhatsApp group later. Sorry for inconvenience. Thank you, Doctor.
So you nebulizer video satu Okay. Siapa?
Me, Ilya Maisara, Nur Ilya Maisara.
No Ilya?
Maisara.
CPR, okay.
Okay. Assalamualaikum. My name is Nur Ilya Maisara. So today I will present about the cardiopulmonary resuscitation or CPR in pediatric. So this is the flow of my presentation where I will start with the introduction, change of survival, and lastly the pediatric basic life support. So for the introduction, the cardiopulmonary resuscitation is the definition is an emergency life-saving procedure to support and maintain breathing and circulation in patient who has stopped breathing, or we call as a respiratory arrest, or the heart has been stopped. The CPR is the combination of the rescue breathing and also the chest compression. The purpose of doing CPR to restore and maintain the breathing and circulation and provide the oxygen and blood flow to the heart, brain, and other vital organs. In adults, the cardiopulmonary arrest is often due to the cardiac origin. Meanwhile, in the pediatric patient, it is mostly consequent in the CPR in children. For the chain of survival, so chain of survival is summarize the vital links that need for the successful resuscitation. Most of these links apply to the victim that have both primary and also respiratory arrest. So in the chain of survival, first we have early recognition and call for help. So, for example, if the patient has the chest pain, so it may be the signs of the cardiac arrest. So, by calling the emergency service before the victim collapse can enable the repeat activation of the emergency response system to help the victim as soon as possible. Next is the early CPR. So CPR can be done by the time before the helper comes, and this immediate CPR can increase the survival rate from the cardiac arrest. Next is the early defibrillation. So the defibrillation within 3 to 5 minutes of collapse can produce survival rate as high as 50 to 17%, and this is work better with the CPR. The next one is the post-resuscitation care, is to restore the quality of life and also improve the survival rate of the victim. Next is the pediatric basic support. So pediatric basic support can be done by the trained people and without any equipment. And CPR is done based on this sequence in the pediatric basic support. So the mnemonic is BRS ABCD, where B stands for danger, R is responsiveness, S shout for help, A airway, B breathing, C circulation, and D defibrillation. So I will explain this one by one. For the danger, the rescuer should ensure the external environment is safe and the child is not in danger. And if available, the rescuer can wear the PPE, before further step in the resuscitation. For the responsiveness, the rescuer should check the child responsiveness by gently stimulate the child or ask loudly, "Are you alright? Are you okay?" And if the child responds by answering or moving, we can leave the child in the position where we find him if it's not provide further danger to the child. And after that, we can check his condition and get for help. And we need to reassess the condition regularly. But if the child does not respond, we need to shout for help. For the shout for help, the rescuer should get the help as soon as possible, or we can shout loudly, "Emergency help," so the other people can help us too. If there is more than one rescuer available, one person can do the resuscitation while the other one can go for assistance. But if just only one rescuer present, the rescuer can do the resuscitation first for about 1 minute before going for assistance. For the resuscitation, we need to start with the airway. We need to provide and maintain the airway in the children. So we need to turn the child onto the back and open the airway using head seal and chin lift. So for head seal and chin lift, first we need to put our hand on his forehead and seal his neck back. While in the other hand, we used to lift the chin by put the fingertip under the point of child's chin, and we need to make sure that we do not push any soft tissue under the chin because it can block the airway. So this picture show the correct airway position for the children in the different age. Where the infant should be in the natural position, the small child should be in the sniffing air, and for the older child in the extended neck position.
You punya genetik tu,
If you can provide the better airway in the child while doing the healthy and chin lift, you can try the jaw thrust method, where you can place the first two finger on each hand behind each side of the infant's mandible and push the jaw forward. For the breathing, we need to set the breathing and while doing this, you need to keep the airway open. So we need in this breathing, you need to look, listen, and feel for normal breathing by putting your face close to the child's face and look. You need to look for the chest movement, listen at the nose and mouth for the breath sound, feel for air movement on your cheek. and these actions shouldn't take more than 10 seconds. If the child is breathing normally, we can turn the child into recovery position, and then we can send and go for help, and we need to check for continued normal breathing in the child. But if the breathing is not normal or absent, we need to carefully remove any obvious airway obstruction and give 5 initial rescue breath.
Anda tengok ada department ni
For the rescue breath, for the step, first, you need to ensure the head in a correct airway position. Second, take a breath and cover the mouth and nasal aperture of the infant with your mouth. Second, blow steadily in the infant's mouth and of nose over 1 second, sufficient to make the chest rise visible. Next, maintain the head position and chin lift. Take your mask away and watch for his chest to fall as air comes out. And last one is take another breath and repeat this cycle for 4 times. For infant, as I said, that we can use the mouth to mouth and nose technique. But if you find it difficult, you can use mouth to mouth or mouth to nose technique. If you use mouth to mouth technique, you need to pinch the soft part of the nose to close the nose. And if you use the mouth to nose technique, you need to close the mouth of the infant. And for the children more than 1 year old, you can use mouth to mouth technique. If you have difficulty to achieve the effective breath in the children, you may suspect that the airway may be obstructed. Next, for the circulation, we need to assess the circulation as the signs of the life, and this shouldn't take more than 10 seconds. So for this, you can look for the signs of life such as any movement, coughing, or normal breathing in the child, or you can check the pulse. For the infant, you can try to feel the brachial pulse on the inner aspect of the upper arm. And the child, in the child, you can try to feel the carotid impulse in the neck. But if you can feel for the brachial pulse or carotid pulse, you can try for femoral pulse in the groin for both infant and child. If you're confident that you can detect sign of circulation within 10 seconds, you can continue the rescue breathing and then turn the child into the recovery position and reassess them frequently. But if there is no signs of life or the pulse rate is less than 60 beats per minute, you can start the chest compression with the combination of rescue breathing. For the chest compression should be push hard and push fast. So push hard with the sufficient force to depress at least 1/3 of the depth of the chest, and push fast to at the rate at least 100 compression per minute. And you need to allow a complete recoil of the chest after each compression. For the step, first the location of the compression is at the lower sternum area. And then compression should be sufficient to depress the sternum by at least 1/3 of the depth of the chest, where approximately 4 centimeter in the infant and 5 centimeter in the child. And then release the pressure completely. Then repeat at the rate of the 100 to 120 per minute. You need to allow the chest to return to its resting position before start the next compression. After 30 compression, tilt the head with the chin and give 2 effective breaths. Continue the compression and breath in the ratio of 30 to 2. So the technique that for the chest compression that you can use for the infant, you can use the tips of 2 fingers, like in the picture, or you can use the 2-tongue chest compression technique, like in the picture. And for the child, you can use the heel of the one hand over the lower sternum, or in the largest child, you can use 2 hands with the fingers interlocked. So this summarize what I have shown in the step before, but for the ratio of the compression to breath, for one rescuer, you can use the ratio 30 to 2. If there is another rescuer available, you can use 50 to 2 ratio. And this resuscitation should be continued until the child shows signs of life, or the further qualified help arrive, or you become exhausted. So this is the link for video for chest compression in the child and the infant.
Usually chest compression in hospital kan kita buat sekali dengan intubation tau. Kita tak pakai mulut kita pakai muah-muah kita tak pakai itu kalau kat luar Tapi biasa kita medical ni kita pakai kita intubate the patient Kita synchronize with the ventilation CPR ni CPR ni included the ventilation with intubation. Okay, tengok video you
Actually I don't offer the video.
Tak ada video juga?
I just share a link because I can't put the
nak video semua apa-apa. 3 orang tak ada video. Kan aku tahu dah, you have to be with video because it's a learning process. Ada lagi apa ni?
Just for the defibrillation.
Okay
For the defibrillation, early defibrillation is one key of the link in the chain survival. So before the defibrillation, you need to assess the need of the child to the shock, and then attach the AED, automated external or manual defibrillator. But this attachment shouldn't be interrupt the chest compression. After the shock, you immediately continue the CPR. For the infant and small child, the manual defibrillator is recommended as you can lower the dose. And after resuscitation, you need to turn the child into the recovery position. So in the recovery position, the child should be in the 2 lateral position, head in the dependent position, then position should be stable, safe and comfortable. So this is the step on how to do recovery position in the child. You can read later. And this is the algorithm on how to do the pediatric physical support based on the illustrated textbook. That's all from me.
Okay, ada lagi? Ada lagi tak?
Today. The last presentation.
Okay, tak apa. Bila lagi you ada lagi teaching ni? Sambung dia? 4 orang lagi kan?
Lagi 5 orang on Tuesday next week.
Okay.
For next week, is it at 12 o'clock also?
12 o'clock
Okay.
Okay.
Thank you, Dato.